Thank you for that very generous introduction, and I'm so pleased to be here today. Also, I just want you to know, because we have such an intimate group today, that I welcome your questions at any point. The only problem will be, because of the lighting here, I can't always see you when you have your hand raised, so if you have any kind of question, just yell it out if I don't see you with your hand raised, and I'm happy to explain anything that's unclear to you. I want to start out by showing you one of the reasons why we're concerned about the effects of stress on birth outcomes. Low birth weight and preterm birth account for as many as 30,000 neonatal deaths in the United States each year. These are defined, by the way, as deaths during an infant's first year of life. And the way we define low birth weight using clinical standards is that it's a baby weighing less than 2,500 grams, which is about 5.5 pounds. If you can imagine for a moment a bag of sugar in your hands, we're talking about a baby who weighs even less than that. Preterm birth is defined as any delivery before 37 weeks of pregnancy. Normal pregnancies last approximately 40 weeks. And I may use the term prematurity today to refer to either one of these outcomes. These adverse birth outcomes are associated with a variety of health consequences. We see subnormal growth in the infants who are born premature. They are more prone to respiratory illnesses, especially during their first year of life. They are more susceptible to a variety of neurodevelopmental problems, and they're prone to cognitive, attentional, and other deficits as well. These kinds of problems may persist throughout childhood and even into adulthood. And so, for example, we find that children who were born premature are more likely to be in special education than children who were full-term normal birth weight infants. In their adolescence, they're less likely to graduate from high school. And then as they approach adulthood, we're finding increasingly that adults who were premature infants are more likely to develop coronary heart disease, hypertension, and type 2 diabetes. And there is a complicated set of explanations for this, which I will not go into today. But this work originates from something called the fetal programming hypothesis. And finally, for women who were themselves premature are more likely to deliver a low birth weight infant. As if that were not enough to convince us of the important consequences of prematurity, health economists show us that the annual financial costs of low birth weight to families, to the healthcare system, and to other aspects of our social organizations exceed the cost of AIDS, which is often a well-referenced comparison point for the impact of these kinds of health outcomes. So that leads us to need an understanding of the causes of adverse birth outcomes. What is it that contributes to prematurity? Well, we do know that there are medical factors that can put a woman at risk for delivering early or delivering a low birth weight infant. So, for example, hypertension, diabetes, poor obstetric history, and experiencing complications during the pregnancy itself can put a woman at risk for these kinds of outcomes. Nevertheless, those kinds of variables, those kinds of risk factors only explain about half, at most, about half of all poor outcome pregnancies. And the other half are not explained by a medical condition that the woman experiences. And in studies that have provided interventions against those kinds of medical risk factors, we do not find them successful in reducing the rates of prematurity. So that has led scientists to question whether there might be something in the environment of a pregnant woman that would put her at risk of these kinds of outcomes. And in particular, we're interested in the kinds of psychological and social factors that she may experience. And I want to show you on this slide for a moment one of the reasons why we suspect that environmental factors may be important. Look at the rate in particular for non-Hispanic whites of low birth weight and preterm delivery, and compare them, for example, to the rates for African Americans, or what the CDC labels non-Hispanic blacks in the United States. And what you see is a much higher rate of low birth weight and a much higher rate of preterm delivery among groups of women who may be experiencing socioeconomic disadvantages, discrimination, and other forms of stress during pregnancy. So these kind of data really corroborate the notion that there's something going on in the lives of women that may be contributing to their risk of these kinds of adverse birth outcomes. But that raises another important question, which is how might stress affect a birth outcome, right? How might a variable, a psychological variable like stress, end up affecting something that is medical, such as the number of grams that a baby weighs when it's born, or the weeks gestation when a woman delivers? One set of factors that may explain the association between stress and birth outcomes involve a woman's behaviors during pregnancy and how she cares for herself. And we have evidence in some of our own research and in studies by other people examining these kinds of questions that women who experience stress during pregnancy practice poor health behaviors. They don't eat as well or as nutritiously. They're more likely to be inactive, which is a risk factor for some of the outcomes that we study. Stress is a predictor of greater use of cigarettes in pregnancy and alcohol and other substance use. And I want to say that this is a fairly new area of study because generally we know that stress is associated with these health behaviors in other populations. But it's only been very recently that scientists have begun to examine stress and health behaviors in pregnant women. There are also basic physiological mechanisms that can explain how stress might produce these adverse birth outcomes. In the neuroendocrine system, I was talking with some of you out in the lobby earlier about the role of corticotropin-releasing hormone, which is a stress hormone that's involved in the HPA axis between the hypothalamus, the pituitary gland, and the adrenal gland. And it's been shown that high levels of CRH, particularly in late pregnancy, may trigger the onset of labor. There are also studies which suggest that the immune system may be involved in some of these effects. And there is a lot of research in my field which show that stress can increase our susceptibility to infections. So there's some really fascinating studies, for example, looking at people who are exposed to a rhinovirus after experiencing stress, rhinovirus being the virus that causes the common cold. And we know that those people are more likely to actually come down with a cold than people who are exposed to the same virus but are not experiencing stress. In pregnancy, we find that women with higher levels of stress are more likely to have infections, particularly one called bacterial vaginosis, that is a risk factor for early delivery. And last, there is some evidence which implicates the vascular system in some of these effects. And these studies suggest that chronic stress in pregnancy reduces the flow of blood to the uterus and to the placenta and may contribute to risk of lower birth weight. Okay, so we need to step back for a moment, though, because I've been using this term for the last few minutes without defining it. And I actually want to ask you first. Now I can, if I step here, I can see you a little better. I want to know what you think stress is. How would you define stress? What do you think? Speak up so everyone can hear you.
Difficult to concentrate.
Having difficulty concentrating. Okay, good. What else? What do you think stress is? Other people? You want to offer a definition? Wow, that was a wonderful and complete definition. So experiencing, I'm going to try to paraphrase some of the things that you said, some internal pressures that you may feel that you don't have a lot of control over. Okay, so control seems to be relevant. Concentration. Anyone else want to offer some what you think stress is? Depression. Aha, okay. So now we're talking about negative emotions. Well, you're all right, actually. And what I want to show you for a moment is how stress has historically been defined. So there's a long line of work looking at stress as the kinds of events or experiences that we undergo. And these could include major life events, such as having someone important to us die. They can include daily hassles, which are more minor. A good example of that would be the traffic that I dealt with on the way to the lab today. I was almost late to meet with Vivian. So that's a hassle, not as severe, but it's also a stressful stimulus. And some studies have conceptualized stress in terms of major disasters that people have experienced. And most recently, we've seen a lot of examples of that in what has happened to citizens in Oklahoma and Texas and other parts of our country. Now, there's also a line of work, a long line of work, which conceptualizes stress as involving people's responses. And one of you mentioned the inability to concentrate, which could be conceived of as a cognitive response to stress. One of you mentioned depression, which we might conceptualize as an emotional manifestation of stress. There are physiological responses that might include elevated blood pressure, and there are behavioral responses to stress, which might be crying, for example. Recently, psychologists began to suggest that these two lines of thinking were really inadequate, and that if you only look at the stimuli, the events people experience, you don't know how people are reacting to them, what they're thinking about them, what they're feeling about them. If you only look at people's responses, then you don't know whether a person's responses, in a sense, are validated by what's happening to them, or whether this is someone who always cries a lot or always experiences negative emotions. And so the idea underlying this approach is that stress is really an interaction or a transaction between the environment and the person, between what is happening to a person and the way they think about what's happening to them and the responses that they experience. And this way of thinking is really what has guided my research on stress and pregnancy over the last 20 to 25 years. What we've done in our work is conceptualize stress in pregnancy as involving stimuli. These are the events, the experiences, and we look at major life events that women experience, as well as their appraisals or evaluations of what's happening to them, which would be how distressing an event is. Remember, if we don't look at that, then we don't know. For example, we'll take an event like getting married, okay? For some people, getting married can be the most stressful event in their life. Right, I'm seeing some of you smile because maybe that was true for you. For others, it may be a wonderful event, something they've been looking forward to, and maybe they don't associate an event like that with much distress. So it's very important to collect data on the way people experience these life events. We also look at people's more, I'll say, garden variety or chronic perceptions of stress in their lives. So this comes back to the point that you made earlier about feeling like you don't have a lot of control over the things that are happening to you. And finally, the response that we've been looking at in our research is anxiety, as opposed to something like depression, which we could study, in fact. But there's a long line of work looking at anxiety in pregnancy, and we wanted to make our work comparable to that. And I want to just briefly make the distinction for those of you who are unfamiliar with terminology in psychology, that state anxiety refers to the way we're feeling at the moment, okay? as opposed to what's called trait anxiety, which would be your predisposition to be anxious in response to any event. So we're looking at how women are feeling at the moment. And I want to tell you a bit in more detail about one of our earliest studies in which we conceptualize stress as involving these 4 components. And they're the same components that I had just had on the previous slide. These are the major life events. So in this study, we were asking women about all of the things that might have occurred during their pregnancy, whether anyone died, whether they were in an automobile accident, whether they lost their home, whether they had legal problems. These are the kinds of major events that we asked them about. And then we asked them to tell us how upsetting or negative each event was and how much they were still disturbed by that event. Then we also were asking them to talk to us about their perceptions of stress in daily life. And finally, we measured their level of anxiety, state anxiety. So this is the model of stress. And what you'll see on some of my slides is that we have some variables in circles and some variables that are in boxes. The reason for this is that it corresponds to the kind of statistical technique that we use in our research, which is called structural equation modeling, which I don't expect any of you to have to understand to follow today's talk. But variables that are in circles are what we call latent factors or latent variables. Something that is latent can't be measured directly. You know, it'd be really nice if we all had a dipstick or something. You know, when you check the oil in your car with a dipstick, it'd be great if we had something like that for stress, where we could just take one measure and figure out whether a person is under stress. But we don't have that. So the way that we understand these kinds of latent variables is to use the things that we can measure and put them together statistically to see what they have in common. Everybody got that? Okay. All right, so this is one of the very early studies that I conducted looking at stress and birth outcomes. There were 130 women in this study, on the average about 28 years old. They were right near the end of their first trimester of pregnancy. And notice in this study how diverse they were. First of all, this refers to the number who had other children. A multipara is a woman who is not pregnant for the first time. Primipara is the word that describes someone who's having their first child. In this study, 55% of the participants spoke Spanish, and we conducted interviews with them in their preferred language. A majority of them were from Latin America. This was a study that we conducted in Southern California, so these women were immigrants. They had less than a high school education on average, and not all of them were partnered, and even fewer of them were married to the baby's father. So it's a very diverse and somewhat disadvantaged sample. I'm not going to go into much detail about this slide because for this audience, you may not be as interested in how we measured the names of the various measures that we used to ask women about things like the number of life events they experienced, how anxious they were, their level of perceived stress, and we got some information from their medical chart as well. And every time they came in for a prenatal appointment, they were interviewed and we collected this kind of data. Okay, so this again just goes into detail about some of the measures because I thought you might be curious about how psychologists measure these kinds of variables. So in our prenatal life event scale, which is something that I've published and which is now in use in a lot of different places, not only in the United States but throughout the world, we ask women questions like, during your pregnancy, did anyone close and important to you die? And if she says yes, then she was asked, how negative was this? And she was asked to respond on a 4-point scale from 1 to 4. And there were 22 different events on that scale. This is a standard measure of state anxiety. So a sample item from that, we ask women at this moment, right now, do you feel nervous? And then women would report to us either from 1 to 4, not at all, to very much. 20 different items were asked about anxiety. This is the perceived stress scale. So women are asked, This one referred to the last 2 weeks, actually. They were asked, in the last 2 weeks, how often were you upset because of something unexpected that happened to you? And they give their response on this scale from 0 to 4. Okay, so I said I will not expect you to know anything about structural equation modeling, so you're just going to have to take my word for it that statistically we found that there was a lot of association between the distress that women experienced from major life events during pregnancy, their levels of perceived chronic stress, and their levels of state anxiety throughout pregnancy. And this statistical model, the absolute ideal model, would have a fit index of 1.0, so a 0.95 is actually very, very good. What this tells us is that we have measured stress in a way that allows us now to look at its effects on birth outcomes. Now, there's something different about this than in the original model I proposed. Anybody notice what might be different about it? This will not be on the test, but just want to see if you're paying attention. Anybody notice something different about it? I'm missing one, exactly. Anybody remember which one it is missing? I'll give you, it was up here, right? Exactly, the number of life events. So when we looked at our data, one of the things that we learned was that the number of those major events that women experienced were not related to these other things. Were not related to how anxious she was, how much chronic stress she experienced, or the amount of distress. Suggesting that, as I said earlier, what happens to you objectively is not necessarily a good indicator of how much stress you're experiencing. What seems to matter is the way that you're thinking about those events and other things that are going on in your life and the negative emotions that you're experiencing. Okay, so we have this stress variable to work with now. And the question is, does it affect gestational age? So this would be the number of weeks when a woman goes in to deliver a baby, okay? And remember that normal pregnancy lasts 40 weeks. And one of the things we find, this is a statistically significant effect, and what it means is that women with higher levels of stress were 23% more likely to deliver earlier. This is a negative association because as stress goes up, gestational age goes down. They go in opposite directions, okay? And that negative 0.23, if you look here, is pretty sizable because these are all the medical risk variables that I told you about earlier. Remember in an early slide I mentioned that factors like diabetes and hypertension and complications in the pregnancy also can affect birth outcomes. So we measured those and then looked at those in this study as well. And independently, they also have an impact on the gestational age of the woman's infant. So, and notice that these numbers are comparable. And the reason I point that out is because I think we're very accustomed to accepting that medical variables have an impact on our health. But here we see that a psychological variable has equivalent impact on a health outcome, in this case, gestational age. Okay, now the next question is, once we put birth weight into the model, does stress affect birth weight as well? It did. This is also statistically significant. It is almost of the same magnitude of the impact of stress on gestational age. So higher levels of stress were associated with lower levels of birth weight in this study. Women who had higher levels of stress delivered a baby earlier, and their baby had lower weight than women who had less stress. And the last link in this model is between gestational age and birth weight because we want to account for the fact that babies that are born earlier weigh less. So we've controlled for that statistically. So this was one of our first studies that showed in very rigorous methods that stress could affect the outcome of pregnancy. And the kind of stress that we measured in this study was chronic stress. Remember, these women were interviewed repeatedly throughout the pregnancy. And by the way, those life events that are not part of this stress variable, we looked at them independently. They did not predict the birth outcomes. They did not have an impact. So it's not the number of events, but the way people experience stress that seems to affect their health. And I want to point that out because it corroborates a larger body of evidence in psychology that the kind of stress that affects our health is the kind of stress that we perceive. It's when we feel ourselves to be under stress that we are most vulnerable. Okay, so I already went over this with you. I just want to go back 1 second here, which is to show you that this is a little statistical side note here, but after I controlled for the impact of gestational age on birth weight, the fact that we're still seeing an effect of stress on birth weight means that it has an independent effect, and that stress in this study was associated with lower birth weight even among full-term babies. And the reason why that appears to matter is that there's been recent evidence suggesting that even within normal range, heavier babies are healthier, have higher IQ, and have better outcomes than babies that weigh less. Again, even within normal ranges. Okay, so back to this. The third question that this study raises, has to do with the kind of stress that seems to affect birth outcomes. And we might label it, instead of stress, we might label it as emotional distress, because it was very emotionally laden, phenomenological, how anxious women were feeling, how much they felt that they were chronically overwhelmed by the things that they had to do. And that led us to think more about what might be influencing that kind of stress, what might be promoting distress for pregnant women. So in a second set of studies, we started to answer these kinds of questions. One possibility is that people, by nature of what's called their disposition, or what you might think of as their personality, might just be predisposed to being distressed. They're the kind of person, we all probably know someone like this, right? Who is just always kind of flipping out about things that are happening to them in their lives. The opposite of a calm person. So maternal disposition might contribute to distress. A second and important possibility is that it has to do with the way women are appraising or evaluating or assessing what's happening to them in their lives. And the third factor that we were very interested in investigating in this set of studies had to do with the way women were coping with the events that they experienced during their pregnancy. And in particular, to look at how various types of coping might either be alleviating distress or potentially exacerbating distress for women. So we put this together in a conceptual model. This is really what I just walked you through, that stress appraisal, disposition, and coping can all contribute to distress. That's what these dark lines are. And we also accounted for the possibility that the kind of person a woman is might also affect things like the way she views what's happening to her, the way she copes, etc. So we've crossed all our T's and dotted all of our I's, essentially. So the kind of disposition that we looked at in this study was optimism. Optimism is our expectation for what's going to happen to us. Optimism refers to our belief that good things are going to happen to us, or, if we're not optimistic, the belief that things are likely to turn out poorly for us. So that was the type of disposition we looked at in this study. The type of appraisal that we looked at had to do with women's belief that they had control over what was happening to them, control over their health during their pregnancy, control over the health of their baby. And we looked at 4 different kinds of coping. This is another area of study that I've spent much of my career focusing on, and we've developed good measures of different kinds of coping in pregnancy. I'll talk to you in a moment about, in a little more detail about these, but these are 4 ways that are very typical for people to cope with stress, avoiding what they're experiencing. Positive appraisal is kind of looking for the silver lining, feeling that you can grow or benefit from what you're experiencing. Prayer is fairly obvious. I don't think I need to define it for you, but what I will say about prayer is that it's an understudied topic by psychologists, which is It's both surprising and probably unwise, because in a lot of studies we find that prayer is one of the most common ways that people cope with stress. Preparation is the fourth way of coping that's particularly germane in pregnancy. So we looked at things like what women were doing to prepare for the arrival of the baby, or what they were going to do after the baby came. Okay, and distress is the same variable that we looked at in the previous study. So here we go. This gives you a portrait of the kind of women we studied. In this study, we had 167 women. They were older than you saw in the first study. These were all women using the high-risk prenatal clinics at Stony Brook University. So they're a very different kind of sample. They had to have private insurance in order to be seen in this clinic. On the average, they were in the middle of their pregnancy. They had, on the average, 2 of those medical risk factors. They were predominantly white. They were well educated. They had a comfortable income, and the vast majority of them were married to the baby's father. So once again, a very different kind of sample than the first. I just want to show you this so you see how psychologists measure optimism. We ask 8 items. This is a test, the life orientation test, that has been used with thousands, if not hundreds of thousands of people, so we know norms, we know on average how people respond to these items, so that we can evaluate whether a person is optimistic or not based on their answers to these kinds of items. So here's a sample. In uncertain times, I usually expect the best, and people are asked to respond on a scale from 0 to 4. This is a measure that we've developed in our research and used in lots of different studies. Women are asked 4 questions. Do you feel that there are things you can do to prevent medical problems from occurring during your pregnancy? To what extent do you feel that there are things you can do to keep your baby healthy, to improve your emotional adjustment, and to make your labor and delivery go smoothly? And they respond on a scale from 0 to 3. These are the coping items that come out of one of the earliest versions of this inventory that I developed with one of my former graduate students, who's now a professor at another university. So the avoidance items have to do with either avoiding the problem or just really avoiding being around other people. Positive appraisal, an example of that is, how often did you use this way of coping to manage stress, feeling lucky to be a woman? This is probably an insufficient, in retrospect, measure of prayer because we only had 2 items here. And in subsequent studies, we've elaborated this way of coping. But we looked at the extent to which people were praying about the baby's health and praying for the birth to go well. And finally, we had 8 items asking what they were doing and how often they were doing these things to prepare for the birth and the baby. Distress is measured the same way it was in the prior study. Okay, so I'm going to go through this for each of the 4 ways of coping and just show you. These numbers aren't going to change. If they do, it's just due to statistical rounding. What you want to pay attention to is what's going on down here that's going to change from slide to slide. So first of all, just to explain the top half, women who are more optimistic are more likely to feel that they can control the things that are happening to them during pregnancy. And control, that feeling of control, is protective against distress. Notice that has a negative coefficient, which means that higher control is associated with lower distress. So feeling that you're in control, that you can do things to keep the baby healthy, to improve your emotional adjustment, benefited women emotionally. Optimism itself was a very strong predictor of distress, and this is something that we find in a lot of studies, that people who just have a view of the world, an outlook on the world that is positive, that is optimistic, are less likely to experience emotional distress. Optimists were also more likely to use this way of coping. That's not terribly surprising, right? They were more likely to look for the silver lining, to feel that they were growing, even though, and I mean growing in the figurative sense, not the literal sense, but growing in a beneficial way from what they were experiencing. But here's something interesting. Look, there's no path. There is no path between positive appraisal and distress. It did not reduce distress for women in this study. Here's avoidance. What we find with avoidance is a strong association between avoidance and distress. People who are optimistic are less likely to use this way of coping, but for anyone who uses avoidant coping, it actually elevates distress. And this finding is consistent with this same pattern in lots of other populations. So I guess you're having a general lesson in psychology today too, which is that avoidant coping is a maladaptive way of coping, avoiding the things that are bothering us. There are some exceptions, and they have to do with the kinds of things that really objectively cannot be coped with. In those cases, sometimes a period of avoidance may actually be beneficial. But for most things in life, avoiding our problems is not going to reduce our distress. And as we see here in pregnant women, it elevated their distress. Preparation, kind of out there on its own, right? Optimists were no more or less likely to prepare for the arrival of the baby, and preparation had no impact on distress in this study. And last but not least is prayer. And again, there's no link to optimism, there's no link to control. It's just people who are praying. What do you notice about this? Anybody? It's positive. In this study, people who prayed more, women who prayed more, experienced an increase in distress. And that was very surprising to us. It was counterintuitive. It was not what we hypothesized. But in retrospect, we went back and looked at prayer in this study. And what we found was that on average, the women who reported praying were doing a lot of praying. And we think that maybe what they were doing is what psychologists call ruminating. They were thinking and worrying, oh God, please don't let this happen to me. Please take care of me. Please take care of my baby. And they were doing this all day long. And so that kind of rumination is probably closer to worrying than praying. And that kind of focus increased their distress. So as I said earlier, we have gone on from this study. I'm not going to be talking today about some of our other studies of coping, but we have gone on to look at other kinds of prayer and to confirm that, in fact, prayer itself may not be harmful. It's the kind of over-reliance on it that may be an indicator that someone is extremely worried. Okay, so I'm going to skip the first two bullets on this slide and focus on this. Because around this time, I started to get a crop of graduate students. You know, I trained doctoral students, and this crop was so interested in optimism that once they saw the early findings from our studies, they wanted to know what else might be a benefit associated with optimism in pregnancy. And so they took me in a direction I had not originally intended to follow, but had turned out to be quite fruitful. So in this study, I'm not even going to give you the details about the number of participants in this study or how often they were evaluated, but one of the things that we found in this study is that stress was inversely associated with optimism. So people who are optimistic experienced less levels of stress in this study. This is a study of pregnant women. They're not at high risk. They were mixed medical risk. And here's something very interesting. We were interested in looking at why optimism might predict birth outcomes. And one of the things we found is that women who are optimistic are more likely to exercise during their pregnancy. And exercise is associated with better birth outcomes. Now, it may not be exercise alone that these women were benefiting from. This could be what I would call a proxy variable. What it really means is that optimistic women take better care of themselves during their pregnancy. And as a result, they delivered later, within normal range, but they were less likely to deliver early. Notice medical risk is also included in this model. And look at that. There's a direct association between optimism and birth weight in this study. So women who are more optimistic had babies that weighed more, again, within normal range. So these women were at lower risk of delivering a low birth weight infant. And I should say that it's this study that landed me in the famous book, What to Expect When You're Expecting. I bet all of you who've been pregnant or know about pregnancy know of that book. They don't mention my name. They don't even mention Stony Brook University, but they do talk about this study. And I have to say, it's kind of funny to me that of all the things I've ever done in my career, that this is the one that attracted the most attention. I guess it's kind of like a sexy finding. Everybody wants to know that, optimism, that's a really cool thing that seems to affect birth weight and gestational age. Okay, so I'm just going to kind of quickly walk you through some of the other studies that we've done. I'm not going to give you a lot of detail about them. I just want to give you a sample of some of the other things that we've done in our lab. The first is to look at the risk of cesarean delivery that's associated with stress. And we care about this outcome for lots of reasons. You're probably all familiar with some of the medical risks associated with surgical deliveries or cesareans or C-sections, as you might refer to them. There's higher risk to mom and baby for these kinds of deliveries. This is major surgery. There are also psychosocial consequences of C-sections, and we've done some research on that as well. It turns out that when a woman has a C-section, particularly an unplanned C-section, the baby is interacted with less. Babies are played with less. They're touched less. They're less likely to be breastfed. Women are less likely to have another child after a C-section. And women tend to be more dissatisfied and have a higher risk of postpartum mood disturbance after a surgical delivery compared to a vaginal delivery. And I just want to say, particularly since there are some pregnant women in the audience, I'm not advocating that you avoid a C-section if it's medically indicated, but just that we be concerned. People have misconceptions, no pun intended, about C-sections. And some people believe that recovery periods are faster or easier, when in fact the opposite is true. So we looked at the role of stress in the risk of cesarean delivery. This was a study of women who, for all medical reasons, were expecting a normal, spontaneous vaginal delivery. They had no medical risk factor that would have led them to believe that they were going to have a C-section. And what we did was look at stress during their pregnancy, and what we found was that at the time of their delivery, stress was associated with a higher likelihood of receiving medication and a higher amount of pain medication during delivery. As a result, their babies had more heart abnormalities, which led, in some cases, to the performance of a surgical delivery. There's also a direct association there. And we controlled for any medical risk factors that might have made them more likely to receive pain medication or to have the C-section. So stress has an indirect effect on women's risk of cesarean delivery. A second project that we've been involved in had to do with another way of measuring and conceptualizing stress in pregnancy. And here's what led to that work. I told you about this great conceptually elaborate approach to measuring stress in pregnancy, but it may not be easy or practical for a healthcare provider every time a woman comes in for an appointment to give them a list of items and ask about how anxious they are and how many major events they've experienced, how distressing those events were, all of the other things that I talked about measuring. So we've been trying to develop something that would be brief, but that would provide the same kind of ability to predict birth outcomes if healthcare providers were to be able to use it in their offices in actual practice. And I've spent a lot of time over the past 5 or 10 years developing this measure, and it's now been translated and being used in China, in Thailand, in Mexico, in a variety of other Latin American countries, around Europe. I've been collaborating with some people in Ireland and the UK. So it has turned out to be a very valuable measure for people to use both in healthcare and in research. So I'm just going to show you another one of these structural equation models from this study looking at pregnancy-specific stress. So this is a measure that asks women the extent to which they're worried or upset about things that have to do with the pregnancy itself. Changes in their body, changes in their relationships with other people, concerns about the labor and delivery, distress over some of the physical symptoms that a woman may be experiencing, and things that really pertain to the pregnancy itself. And one of the things we found in this study is that this kind of stress was related to all of these health behaviors. Women with higher levels of this kind of stress were more likely to consume caffeine. They were more likely to eat junk food and fatty foods. They were less likely, to eat nutritiously. They were less likely to take their prenatal vitamins regularly, and they were less likely to exercise. And they were more likely to smoke cigarettes. And as a result of smoking, they were at risk of delivering a low birth weight infant. So cigarettes were directly associated with lower birth weight because of high levels of stress. Also, stress had a direct effect on gestational age in this study. A third line of work that we have been investigating harks back to one of the early slides I showed you today about the disproportionately high rates of preterm delivery and low birth weight in African Americans. And we suspect and have done some research looking at the role of racial discrimination during pregnancy and its effects on birth outcome, and whether this kind of discrimination may elevate stress or maybe it's a separate variable that has yet to be ascertained. But nevertheless, being black, female, and pregnant in the United States can create a variety of difficult circumstances for women. And we've corroborated that in a number of studies. I'm just going to show you. This is from, I'm going to skip this slide. This is from a study that is not yet published, where we've just started analyzing data, and we're looking at what we call gendered racism in pregnancy in this study. So we're asking women questions like this. How often do you feel that people make negative assumptions about you based on being a woman of your racial and ethnic background? And we ask very specific questions, whether people are making assumptions about their sexual partners, whether they would be a good mother, whether they receive public assistance. And as we anticipated, we are finding that women report experiencing this kind of discrimination. Just as an aside, I wasn't even going to bring this up today, but I will mention that we've also done an experiment recently where we provided our participants with photographs of a woman, and we were able to change her race in the photograph. And in one version, she's pregnant, and in one version, she's not. And we looked at people's perceptions of those women. And we did find evidence of discriminatory attitudes towards the black pregnant woman compared to the other groups. So this is not something that people are imagining that they're experiencing. This is a real response. And we have some pregnancy-specific items in this study, too. During your most recent pregnancy, how worried were you that people were doing these kinds of things, making assumptions about your marital status, about whether you would need public assistance to help with your child during pregnancy? And in this study, we combined women who are African American or Latina, compared them to white women, looked at their level of stress, and we did find that women of color had higher levels of stress in pregnancy. I know I'm going through this quickly, but these are some of the measures of stress that we included in this study to see if they might explain why women of color experience higher stress. And what you see is that the variables that really seem to matter are these. This has to do with events relating to sexism. That wasn't really an important variable. But the ones that did seem to be the most important, that were associated with race as well as with stress, are these two here. And I just show them, I think, on the next slide. That this is really what we're finding evidence for. That women of color experience more gendered racism in general, and gendered racism with relation to the pregnancy itself that contributes to their stress. And we're now conducting a study at Stony Brook looking at birth outcomes in these women. The last study that I want to mention to you is a study looking at interpersonal violence in women. This is based on a large study that was conducted in the state of Iowa, looking at levels of stress and domestic violence, or what we call interpersonal violence or battering in pregnancy, and its impact on preterm delivery. And I'm just going to call your attention to a couple numbers here. These women are 1.3 times more likely to deliver preterm if they had high levels of stress. So these are not women who are reporting abuse in their pregnancy, but they are reporting high levels of stress. But look at what happens among the women who have the combination of these risk factors. Women who are reporting abuse from an intimate partner, as well as having high stress, are twice as likely to deliver a preterm baby as women who, compared to women who deliver a normal birth weight infant. So the combination of stress with interpersonal violence seems to be a particularly potent set of risk factors. These are just numbers for that study, which I don't have to show you. And this is really just a reminder of why I do what I do. And it has to do with helping to ensure and protect the health of all women and their children. And I'll tell you, these happen to be my children. This photograph was taken a very long time ago. That guy is now 18 and she's 11 years old. I want to thank all of the various funding sources that have provided support for our research. And I couldn't do this kind of work by myself. So you see a long list of collaborators there at various places, both at Stony Brook and throughout the country. Thank you so much for listening. So I'm happy to take questions. Is that okay, Vivian? Sure. Any questions, comments? Yes, you said you're a psychologist.
Yeah, I'm a cognitive psychologist.
Wonderful.
So I have 2 questions.
Uh-huh.
How do you actually treat people, since you're doing this as a longitudinal study and you're taking measurements over time? How do you treat the changes in people's stress levels? And whether you're actually looking at it as a factor that can mediate a low birth weight, or is potentially treatable and that can actually influence an interventional style?
Okay, good, great. It's nice to have a cognitive psychologist in the audience to ask those kinds of questions. So 2 questions you raised. One had to do with changes in levels of stress over pregnancy. And in general, what we find in our research is that stress is highest in the 1st and the 3rd trimesters. So let's see, from your visual perspective, it goes like this, right? There are people in California, actually in Southern California, who are doing research which suggests that when you don't see some of these normal patterns, that those women themselves may be at risk. Generally, the departures across trimester are not that great, so we see a lot of stability in levels of stress across pregnancy. So I haven't found anything really notable about those changes. Statistically, we do control for them. Your second question had to do with interventions, and I will say that that's really not my area of expertise, and so I've left that to others to develop interventions. I have been involved in consulting in a lot of studies looking at interventions for women in pregnancy. Generally, they have to do with things like providing social support to women who don't have supportive networks. I was involved in a study a number of years ago. This is a very interesting study because it was conducted in rural areas of South Carolina where women just lived in these really remote areas and they couldn't even really get to each other. And so what they did was provided people with internet access to a nurse 24 hours a day if they had any questions about their pregnancy, as well as providing them with contact with every other woman in the study so that they could communicate with each other. And I have to say, this was really before the highlights of social media were this kind of preceded all of the stuff that's happened in social media since then. And some of the other research now that I've consulted on has to do with teaching women beneficial ways of coping. But I have to tell you, no pun intended, I'm not highly optimistic about those studies because we don't really know, number one, if we can teach people adaptive ways of coping. Nor do we know that the value of the kind of coping we would teach people to do is going to benefit them in the same way as people who kind of naturally on their own use those ways of coping. We do know from things like cognitive behavioral therapy, which is used by clinical psychologists, that the way we think about the things that are happening to us can be altered somewhat. The question is whether you can change it in a short period of time. That is yet to be determined. But yeah, there are some people doing some of that kind of work. Does that answer your questions?
Yeah.
Great, thank you. Sure. I'm going to grab my water while I talk with you.
I assume that all of the people in your studies are actually having single births and not necessarily multiple births. How does multiple birth play into that? Because low birth weight and gestational age are factors.
Yes. So there are two ways to control for that. One is statistically, which we do, and the other is by selecting, unfortunately, only women who are having singleton pregnancies. So we've had to do either one of those options in our studies. And yes, women with multiples. I was actually involved in a study. We didn't get funded to do the study, but I have a colleague at the University of Virginia that I've been working with, and she proposed a study that provided massage to women who are pregnant with multiples, particularly those who are having preterm labor, because they often are hospitalized and they're just kind of laying around in their hospital room, and we wanted to decrease their levels of stress and see if we could prolong the pregnancy. As I said, we didn't get funded, so we couldn't carry out that study, but I think we'll probably revive it at some point. Yeah. Any other questions, comments?
I found two things very interesting. One is like the cost is more to the expenses than the cost that is to dedicate for HIV.
Yes.
And this is something that we rarely hear.
Exactly. Mm-hmm.
And the other thing is that many of the stress coping,
Mm-hmm.
they really apply to everyday.
Yes.
I think they are not only directed towards pregnancy.
Yes.
There must also be some kind of relationship between stress and our proning to get diseases or
Mm-hmm. Mm-hmm.
get sick.
Yes, absolutely. And I mean, we have a lot of evidence that people are more vulnerable both to acute illnesses as well as some of the diseases. Now, whether stress causes chronic disease is doubtful if it were only stress. But in combination with some pre-existing vulnerability, either family history or genetic factors or poor health behaviors, absolutely, we have a lot of evidence that stress contributes, not necessarily, as I said, to the origins of those disease, but to its severity and to whether people will survive. And there are lots and lots of people doing work in the area of cancer, heart disease, autoimmune disorders, with very compelling evidence. I mean, even things like with obesity, there are people at the University of Pittsburgh which show that under stress, as people gain weight, The person under stress will put it on as belly fat, abdominal adiposity, compared to people with lower stress who are eating the same number of calories and also becoming obese, but not developing abdominal obesity. It's abdominal obesity, which is called android obesity, that's the greater risk for heart disease. So, I've been trained and trained my students in what we call the biopsychosocial approach to health, which is that health and illness are caused by a combination of factors, psychological factors, biological factors, and social factors, and that we can't isolate any one of them without examining how they interact with those other risk factors. So you're absolutely right in making that observation. I think you said Amber is your name? Yeah.
So the link between stress and the negative effects is there. What about like cliche remedies one can, is that still there as a recommendation, to combat stress, chronic stress especially, whether it's cognitive behavioral therapy or meditation? I mean, is that still being advocated, and does that work, and does that help combat chronic stress?
Boy, that's a very big question. I would say that from what we know, increasingly we're learning to tailor our interventions to what works for people. And so for one individual, meditation might be useful. For another individual, distraction might be useful. There are all kinds of interventions that people can employ. And I'll tell you, in some of our own studies, we've been looking at people's ability to express their negative emotions. So, one thing I didn't mention today is that simply participating in a study like this probably reduces women's levels of stress. We have no way of knowing that, but we infer, because the women tell us, you're the only one who's asked me, how am I feeling? And they find great value in that. And we know from other studies that simply having an opportunity to express negative emotions, either by talking to someone or writing it down, it doesn't even have to be shared with another person, but simply expressing it is beneficial and not only reduces levels of distress, but has been shown to improve physical health as well. So that's one of the interventions that I'm very interested in, because it enables women to do this on their own. You don't need to go see a therapist. You don't need to do anything extraordinary or costly. But I hope that we'll continue to move in the direction of kind of arming people with what they need on their own to cope effectively.
There's sort of an internalization aspect to stress or chronic stress that keeps it going. So that's a pretty powerful statement about just expression.
Mm-hmm.
It's pretty vital.
Mm-hmm. Yes, being able to express what we're experiencing. Yeah, absolutely.
There are no more questions. Let's thank Marci again.
Thank you. Thank you so much.